going to give you a couple of examples of our experience here in Ireland about managing our diabetic foot patients during COVID-19. So it's been a very challenging 12 months for everybody, I think. And this is just our experience and what we've been able to achieve during the last 12 months. So basically, so we sat and we were discussing what we needed to say at this meeting, and we said that in terms of diabetic foot and COVID-19, there is no normal. And I know this time last year we were making algorithms, and there's some amazing algorithms and treatment protocols that have been developed around the world. But what we found is that these things, they change so rapidly. What worked as an algorithm or a protocol today may not work tomorrow, because the crisis is adapting so quickly. So the one thing we've done is we have personalized the care. So for our diabetic foot patients, every person has the individual care plan dependent on their specific pathologies and their individual circumstances. We provide services across a large geographical area. So with various forms of lockdowns, it's been very challenging for people to access services. The other thing there is talking about diabetic foot care is an essential service. It is as important as any service. The main services at the beginning of the pandemic that were able to continue in our institution were essentially oncology services. So we made the case very early, fortunately, with some of the literature about diabetic foot and its comparisons to cancer, that, you know, diabetic foot is an essential service. And we have been very fortunate that we have not reduced our service capacity at all. The challenge is our patients and our potential patients and healthcare professionals may not necessarily have got that message. The messages in the media from public health is stay at home, don't go anywhere. So it has been very difficult to try and get that balance between we're open, we're essential, with the communicating correctly. We have employed quite a lot of telehealth. We've not done video consultations, but what we have done is we've encouraged people to send in photographs via email so that we can assess the progression of their wounds. And we've done a lot of work with primary care nurses. So from an administrative perspective, I suppose it's been very much an increase in administrative burden for the diabetic foot services through negotiating different services, you know, with no surgery happening on site, being able to arrange surgery in different locations, even within the primary care setting, as I know Professor Bolton was saying earlier in Manchester. These patients are incredibly complex, so we need to ensure that they're still being able to get access to care. We have a team of superheroes to support us. We're very fortunate that our team have worked tirelessly out, whether they're podiatrists, endocrinologists, vascular surgeons, orthopedics, infectious diseases, all of them have worked incredibly hard together for the benefit of our patient. And we can say anecdotally, although we haven't finally finished analysing our data, but we have not seen any increase in our amputation rates between 2019 and 2020. So I just have a couple of examples from patients that we've actually seen since Christmas. So this is one example, you know, of the problem with flow, and I know we talk about toe and flow in the diabetic foot. So this was a GP referral who telephoned us on New Year's Eve about a patient who'd already had attended the accident and emergency department and sent home because they were not deemed to have a problem. So we triaged and saw this individual in our diabetic foot clinic, who presented with critical ischemia, rest pain, pneumocrosis, and erythema. So this was an emergency from our perspective. We were able to get a CT angio the following day, and our vascular teams also saw him the day after. So what we were able to achieve with one of the agreements we have here in Ireland is that while the public hospitals are all operating COVID, we have got an agreement with some of the private hospitals to provide non-COVID surgery. So again, within the space of 4 days, this individual had been admitted for angioplasty and antibiotics as well, and was discharged from the private hospital within 48 hours using the outpatient antibiotic therapy service and has been followed up in our clinic. So they've had the equivalent of an inpatient admission provided through an outpatient setting. So the next example I have here is one of infection. So again, we have a gentleman who over Christmas, previous history, ulceration over the 1st and 5th metatarsal head, who developed new blistering that we gave oral antibiotics to because there was signs of local infection. It was a very complicated medical history with a stoma and non-Hodgkin's lymphoma, end-stage renal disease, heading to dialysis. So again, what we were able to do is we were able to remote review with our colleagues in infectious diseases. And again, we were admitted to the intravenous antibiotic program. And again, this was all started in the outpatient capacity and is now doing quite well on OPAT, which again has been very helpful for him and for us. But it doesn't always work like that. So what we have here, and I've called this the perfect storm. We have a lady who presented to the emergency department the day after Christmas, which is known as Stephen's Day here, and it invariably is the day when everybody presents A&E. So this patient had been cocooning with our colleagues in community nursing for 8 months. Developed a small lesion secondary to footwear in March 2020, was being seen by the community nursing service twice weekly. She's feeling unwell on presentation with a wound that's probing to bone. She also has known vascular disease. She had 3 courses of PO antibiotics via her GP. So the problem with this is that the message that I talked about here about services staying open did not get there. So when this lady did present, she has ischemia, has an osteomyelitis, and then COVID-19 as well. So we have COVID-19 infection and ischemia. So she needed to be admitted to the hospital via the COVID pathway. So this has been a really challenging case because she's old and frail with lots of comorbidities. We've been unable to offer her any form of vascular intervention partially due to the access issues to theatre, because Ireland's seen a spike in cases and to ICUs. So that, and of course, she's not doing particularly well with the COVID because she's a lady in her 80s. So message from all is life-saving versus limb-saving. So in this case, we've prioritized her COVID, and she's doing quite well with her COVID. However, it is likely that after this, she'll need to go on and develop an amputation. So I will summarize to say this is the Irish perspective. I'm not saying it's right, I'm not saying it's wrong, it's just our experience. There is no normal in these times. There is no normal. It changes every week, every day almost. You need to personalize the care for your patient as much as you can so that they can understand the system and navigate it appropriately for good outcomes. Diabetic foot care is absolutely an essential service, and this needs to be forced amongst our hospital services, our outpatient services. And it's really interesting, Alfred, what you're saying about biomechanics. This is something we're seeing as well. The biomechanics and the orthotic services for patients in remission have essentially been shut down for over a year. Of course, this is having a huge knock-on effect on people caught in this loop coming back through the doors. So use telehealth when you can, but being aware that there is a massive administrative burden and complexity of care with these patients, particularly with COVID-19. Trying to balance who you see versus their risk of COVID in the institution is challenging. But with your team of superheroes, and I forgot to take a picture of our last Zoom meeting, because now all our meetings are like this one, held over Zoom. And if we can able to do all those, then we shouldn't see a massive increase in amputation. So thank you very much.